Grateful to the DG sir who has given me opportunity to edit all those guidelines for Ayush system regarding the musculoskeletal disorder, and I am very thankful to the Dr. Gauri Sen Gupta, DDG Director of this institution. So I will tell you about the description of these common problems, musculoskeletal problems, and these are kept for all the Ayush system because all of you know that these are very chronic problems. These are very disabling, causes disability, lot of morbidity associated with that, and also there is a variability of the treatment. There is no certain treatment exists. On daily basis, the researches are going on to just to improve the treatment, but there is no treatment available. So it's a holistic treatment which is required from all the specialty, all the Ayush system, not only the modern medicine. So, and we all know there is no permanent cure unless we do something surgically. Okay. So unless we do something surgically, it is not possible for us to cure the problem. So that's why these things are kept, and we have to learn. You know about these things in your system. My previous speaker has already talked about various things. So I will just focus on the brief part. What are these things? How we diagnose them? What are the essential investigations which are required? What is not required? And what are the red flag signs? When to refer patients? We know how to treat patients and when to treat patients, and we should also know when to refer those patients, because many a times patients are treated by the physicians outside, and they keep on giving drugs and drugs and drugs. The diagnosis is not established, and patients end up with a lot of complications. So we have to know that yes, the time has come now to shift the patient to some other higher center or to the other system of medicine. तो आयुर्वेद तो हमेशा से ही सबको मतलब हर चीज़ को ही ट्रीट करता है, ठीक है. मैं आयुर्वेद के बारे में मुझे भी थोड़ा सा ज्ञान है कि एक श्लोक है जो मेरे किसी फ्रेंड ने सिखाया था. स्वस्थस्य स्वास्थ्य रक्षणम आतुरस्य विकार प्रश्ननम च, ठीक है, शायद सही बोला होगा मैंने. तो स्वस्थ के स्वास्थ्य की रक्षा करना और जो डिजीज्ड हैं उनको क्योर करना, है ना. तो इसी फिलॉसफी को लेके चलते हैं, ठीक है, क्योंकि अगर हम सब लोग एक साथ नहीं जुट के आएंगे आगे तो हम शायद लोगों को ठीक नहीं कर पाएंगे, ठीक है. ओके. So the first diagnosis is osteoarthritis. So what is osteoarthritis? Osteoarthritis is basically a degenerative problem, involves the articular cartilage, and it is commonly associated with the aging. Nowadays young patients are coming up because of the morbidity, because of the lifestyle, ठीक है. Ayurveda also talks about the lifestyle, जीवन शैली, खान पीन, यही बात करते हैं ना आप लोग. तो इसका प्रभाव, ये बात सही है कि जीवन शैली और खान पीन का प्रभाव भी पड़ता है, ठीक है. तो ओबिसिटी बिकॉज ऑफ खान पीन, एजिंग, दे कैन कॉज osteoarthritis. So any joint in the bodies can be involved. Mostly the weight bearing joints are involved, like knee, hip, spine, ankle, and the other joints like wrist, elbow, shoulder. Even the spines are also involved. So I will discuss as a separate entity. So types could be either it is a primary because of the aging process, because of the imbalance in the wear and tear process, or because of the secondary causes. Secondary causes could be some congenital problem in the bone, some bone defects, maybe some trauma which can cause the post-traumatic degenerative arthritis. It could be because of the metabolic conditions. There are several metabolic conditions like hemochromatosis, आयरन बॉडी में डिपॉजिट हो जाना, उसकी वजह से वो कार्टिलेज में भी जाके उसको डिस्ट्रॉय करता है. और because of some neurological problems like Charcot joints can lead to neuropathic joint can lead to osteoarthritis, and then vascular and bone related issues. So these are the several risk factors for the osteoarthritis. I will not going into the details of all those things, just to show you some slides, and will push go for the further one. So these are the certain risk factors which are identified in a modern medicine for osteoarthritis. So how we can diagnose them? So the American College of Rheumatology has set up certain guidelines based on the experts' opinion, based on the research published in various journals, various meta-analysis, and they have published certain guidelines, and based on those guidelines we can easily diagnose osteoarthritis. So for example, in case of knee, patients have, most of the patients present with the pain, दर्द हो रहा है, कोई एजिंग पेशेंट आ रहा है, कह रहा है दर्द हो रहा है मुझे, you can suspect that he or she is a case of osteoarthritis. Stiffness, not able to walk, रात में सो नहीं पा रहे हैं, not able to sleep, sleep disturbances, और कहता है जब मैं जीना चढ़ता हूँ तो कट कट की आवाज़ आती है, crepitus, joint crepitus, or there may be some enlargement of the joint, सूज गया, मोटा हो गया joint. So any of the complaint can be a osteoarthritis. Similarly, osteoarthritis of the hand and metacarpophalangeal joint, or carpometacarpal joint, can involve the females, and sometimes these nodular swellings are there. Some fancy names are there like Bouchard's nodes and Haberdon's nodes. These are the terms which are used in the modern practice for osteoarthritis of the hand. So when to suspect? You have to see for the cardinal features. Pain. Ask for the nature of pain. दर्द कैसा हो रहा है? How severe it is? And it is very variable from patient to patient. It varies from patient to patient. And then you have to ask for the stiffness. Usually in osteoarthritis, the stiffness is short lasting. 30 मिनट से कम होगी, थोड़ी देर हुआ. It's like a old car. चल नहीं रही है, धक्का दिया, चलने लगी. ठीक है? It's like that. तो stiffness होगी, but it is a short lasting stiffness. Then sometimes patient have swelling, there may be deformities. आपने देखा होगा patient ऐसे ऐसे चलते हुए दिखाई देते हैं आपको, या किसी के पैर knock knees हैं, या फिर varus valgus deformities होती हैं. Then there will be, because of that, patients have developed fatigue, sleep disturbances. Some patients undergo depression, and there will be a reduced functional ability, activity of daily livings. जीने नहीं चढ़ पा रहे हैं, आलती पालती नहीं लगा पा रहे हैं, चौकड़ी मार के नहीं बैठ पा रहे हैं, ज़मीन से ऊपर नहीं उठ पा रहे हैं. इस तरीके की जो कंप्लेन होगी, that is for the osteoarthritis patients. So when you examine, there will be a joint line tenderness, especially on the medial side in weight bearing joint, or there may be bony crepitus, swelling, reduced motions. Because of the patient is not able to walk, you may get some wasting also, and then there will be deformity, and sometimes because of the gross deformities, patient may develop instability of the joint also. चलते चलते बताएंगे कि पैर एकदम से गिव वे हो रहा है, इस तरीके की कंप्लेन होगी. So how will you diagnose? A simple test, plain X-ray. Simple test, plain X-ray. For example, for weight bearing joint in knee, X-rays, both knee, you have to, because you have to compare both knee, AP standing, weight bearing, and lateral views. And then there is no role of joint aspiration, there is no role of MRI, CT scan, there is no role at all. And there is some classification, we call it as a KL classification, based on the number of osteophytes present and the amount of joint space narrowing. So based on that, we can make diagnosis. So, but for any diagnosis, we must know about the differential diagnosis, because disease can mimic anything. So you have to look for other diagnosis. For example, bursitis, there is a bursa around the joint which can be inflamed, or maybe some inflammatory pathology, or some infective pathology, post-traumatic, gout, because if the one joint is involved, you can suspect gout also, or neuropathic. So any differential diagnosis can fit. But remember, in any case, in our country, we always look for, because three things can be serious. One is trauma, another is tumor, and another third one is tuberculosis. So in every case, you must think that these could be the causes if osteoarthritis is not the cause. So always think of trauma, tumor, and tuberculosis. So treatment I will not discuss, but remember one thing, there is no role of MRI. There is no role of MRI, and we have given emphasis while we were making these guidelines. We were making how to make diagnosis clinically and use less or less modalities, because MRI give you more information which are really not required unless you suspect that it is he or she is a case of tuberculosis. Opioid should never be used, because many a times पेशेंट आता है दर्द में आराम नहीं आ रहा, आपने एक गोली दी नहीं आराम आया, दो गोली दी नहीं आराम आया, आपने फिर NSAID से आपने स्विच ओवर कर गए, ओपियोइड दे दिया. तो never use opioids. I know that you people will use your Ayush system of medicine, Ayurveda drugs, but these drugs are still used by many of them. In all the practice, all those medicines are used, so I just say don't use them. There is no role of nutraceuticals. आयुर्वेद तो खान पान की बात करता है ना, और खाने में ही सब कुछ है, हमें पता है ना, खाने में ही सब कुछ है, और जो चीज़ हम नहीं खाते हैं वही मेडिसिन है. तो जो मीठी चीज़ें, गाजर है हम खाते हैं क्योंकि वो स्वादिष्ट है, खा लेते हैं, और वही आयुर्वेदिक दवाई होती है वो कड़वी होती है, नहीं खाते हैं, लेकिन वो भी तो नेचुरली है ना. दीज आर ऑल नेचुरल थिंग्स. सो न्यूट्रास्यूटिकल शुड बी अवॉइडेड, and intra-articular injection, steroid and viscose supplementation has very limited role and can even damage the joint, so it should not be used. So this is the pyramid. In mild cases, one has to educate patient, weight loss, exercise, lifestyle modification, and in advanced cases one can go for the total knee arthroplasty or total hip arthroplasty. So this is all about the osteoarthritis. And when you should refer, even if you diagnose and treat by your system of medicine, but must remember that if any patients present with these red flag signs, please refer those patients to some higher centers or for next system of medicine, like sudden severe pain or buckling of the knee, swelling, warmth, locking of the knee, persistent pain, and consistent knee pain even after the surgery. You must refer those patients. So this is the last slide for this osteoarthritis, I think. Yeah. The another diagnosis, rheumatoid arthritis. ये बहुत common है, और I think majority of the patients show themselves आराम नहीं आता ना, तो वो other system of medicine में चले जाते हैं, और वहाँ पे कभी कभी misdiagnosed भी होते हैं. So diagnosis is important and you must know that. So females are usually involved. There are some genetic factors, and it involves the synovial joints, those joints which have synovial lining. Then the disorder is progressive, disabling, chronic, and it is a multi-system. Not only the joint, the other system of the bodies are also involved in this. So, and then the patients have pain, swelling, stiffness of the joints, and there is a peculiar characteristic of worsening of the symptoms after a period of rest. That is, जब patient सुबह उठता है तो उसको दर्द होता है, and this stiffness lasts for more than 30 minutes. Okay. So, and it is a symmetrical, it is a destructive, deforming polyarthritis, and mostly the small joints of hands, feet, they are involved. And then as the disease advances, the other joints are also involved in this. So there are some extra articular manifestation also, and there is a one peculiar antibody which is called as citrulinated antiglobulin, anti-CCP or rheumatoid factors, जो FC fragment में होता है, they are present. So these patients also have fatigue, subcutaneous nodules, lung involvement, pericarditis, peripheral neuropathy, vasculitis, and hematological abnormalities. So because of the multi-system involvement, all those systems can be involved in this particular problem. So these are the few X-rays you can see. There is a involvement of the metacarpopharyngeal joint, PIP joints. DIP joints are usually spared, and there may be swelling and effusion of the knee, tenosynovitis. Anything can happen, and once the disease is advanced, because the joint gets subluxed and tendon gets torn, so they develop deformity. Sometimes it is presented with the monoarthritis. It is not always that it can present with the polyarthritis. So for those patients, you have to suspect, you have to examine patients as a whole and suspect that it may be a rheumatoid arthritis when everything is not fitting into that. And then you have to investigate further through some lab investigations or through the synovial fluid examination, though it is not diagnostic, but you can just rule out other pathologies to diagnose. And then there is a presence of rheumatoid nodules, which are very characteristic in this problem. They are usually present on the hand and the elbow region. So if they are present, it is almost always diagnostic for rheumatoid arthritis. So the disease can be, you can see patients at a preclinical stage, or in the synovitis stage, or early arthritis stage, or in an advanced arthritis stage. So ये किसी भी उसमें stage में you can get patients. So this is the ACR-EULAR criteria for diagnosing rheumatoid arthritis. In modern practice, we use these ACR guidelines, and based on this, we say that yes, the patient is suffered with the rheumatoid arthritis or not. So whether the large joints involved or the small joints are involved, or patients have serology, which is RA, whether RA is positive, rheumatoid factor is positive, or anti-CCP is positive. The rheumatoid factor is not specific for the rheumatoid arthritis. Please mind it. If it is present and the symptoms are not there, you can't say that it is a rheumatoid arthritis. So because many other conditions can have rheumatoid factor positive, right? So, but the specific marker is definitely anti-CCP, which can be present in about 50% of cases, not in 100% cases. So you have to use your clinical acumen, clinical diagnostic acumen to diagnose. Yeah. And then the duration of the disease, usually it is more than 6 weeks when the patients come first time comes to you. And then you have to see for whether there's a other marker of the inflammation like ESR or CRPs are raised or not. So based on this, you can easily diagnose. And on X-rays, if there is a joint erosion is present, if the joint is eroded, and if subcutaneous nodules are present, as I said earlier, you can easily diagnose as a rheumatoid arthritis. So when to suspect: joint pain, swelling, loss of mobility, usually involving the proximal joints of the finger. Proximal joints of the finger. This is important. Proximal joints of the finger. And then there will be a early morning stiffness or stiffness after the inactivity. There may be history of muscle pain, tiredness, weight loss, general lack of well-being. And on examination, you can see for the swelling, then tenderness, loss of motion, synovitis, joint effusion, redness, limited range of motion. The cervical spine is characteristically involved in rheumatoid arthritis because the C1, C2 joint is a synovial joint. So it is involved in majority of patients, and those patients can present with the neck pain also, or they can have some serious neurological problem because it can cause destruction of C1, C2 joint and severe neurological deficits. So this can be there, or the deformity in later stages. So these are the if you can see, basically proximal joints are involved. This is a rheumatoid arthritis. If the distal joints are involved, it's osteoarthritis. If the asymmetrical joints are involved, some are involved, some are not involved, then it could be a gouty arthritis. So anything can happen. So these are the certain deformities which can be present in advanced cases, like ulnar drift, haan teda ho gaya aise, or there may be some subluxation of the joint, or there may be finger swan neck deformity, Botnier deformity, and then Z deformity of the thumb can be there. In foot, there may be hallux valgus, hamartose. These are the common deformities can be present. So investigation, go for the rheumatoid factor, go for the anti-CCP, CRP and ESR. If these are elevated, then you can very well diagnose. Go for the X-ray. X-ray usually shows reduced joint space, periarticular osteopenia, erosions. These are the common findings are present. But please remember, there is no role of ultrasound and MRI. Again, for the diagnosis. For the diagnosis, there is no role of X-rays and MRI and ultrasound. So differential again could be osteoarthritis is one of the differential, then septic arthritis, psoriatic arthritis, Sjogren syndrome. मैं हर एक को नहीं बता पाऊंगा कि डिटेल में, but I will just let you know. Then fibromyalgia is very important cause. I will discuss later on. Then viral arthritis, reactive arthritis. Every arthritis can be a, pain जो होता है ना, वात पित्त कफ में जो वात होता है, पेन, वायु, that is all are the differentials. Then red flag, any pronounced thing. Early stages you can treat easily. But if things are prolonged, patients develop deformity, not able to relieve by your conventional treatment, more swelling, more joint pain, more stiffness, loss of motion. Patients have rheumatoid nodules, because rheumatoid nodule, if they are present, you can say that it could be a severe osteoarthritis. Then feeling of fatigue, any more symptoms, any development of neurological problem, extra articular symptoms, then please refer those patients to the other system of medicine. Now coming on to the cervical spondylosis, it is again an aging process. Because of the aging process, there is a osteophytosis, what is described, and these patients, usually the C5, C6, C6, C7, these are the segments of the spine which are involved, and the patients may have postural deviation, restriction of movement, muscle issues, neck pain. There may be loss of lordosis. Normally there is a curve in the spine which is lost, neck remains stiff many times, and then there will be reduced mobility, and because of the narrowing, there may be a narrowing of the canal because of the osteophyte formation. So the spinal canal diameter can be reduced, and this can cause several problems like myelopathy. Myelopathy means involvement of spinal cord, or radiculopathy, involvement of the nerve roots. So we have to evaluate as a whole, not only the brain, but the cervical cranial nerve examination, motor examination, sensory examination, and the reflexes in these patients to just rule out or diagnose early neurological issues related with the cervical spondylosis. So when to suspect? Most of the patients are asymptomatic. यहाँ पे भी बहुत सारे लोग बैठे होंगे जिनको cervical spondylosis होगी. Majority of patients are asymptomatic, but those who have symptoms, they are usually occurs after the 40 years of age. They have axial back pain, stiffness, radiating pain because of the radiculopathy, or they have altered dermatome sensation because of the involvement of the nerve roots, or they have even early signs of myelopathy. So the onset of symptoms is usually insidious. बहुत ही धीरे symptoms start होते हैं, and they worse after a period of postural steadiness. आप एक ही जगह थोड़ी देर तक बैठे रहिए, थोड़ी देर बाद आपको फील होगा कि आपकी गर्दन जो है ना अकड़ गई है, स्टिफ हो गई है. So such kind of symptoms is because of cervical spondylosis. And clinical symptoms, usually exacerbation of the symptoms can be there. So the pain is usually pain not only restrict to the neck, but it can goes to the occiput region, it can goes to the shoulders or the interscapular region, anywhere it can goes. And there may be cervical stiffness, there may be some neurological symptoms like tingling and weakness, clumsiness, because of the osteophytes and impingement of the vessels. Sometimes patient may have some dizziness, vertigo, these kind of symptoms can be present. And we have to see whether patients have any myelopathy or radiculopathy. And the radiculopathy patients usually have radicular pain in the arm. There may be loss of reflexes. There may be some weakness of the particular muscle supplied by that nerve root. And myelopathy can have spastic symptoms, bladder bowel involvement. There may be some ataxia. These kind of issues can be present in the myelopathy. So if depending upon the which nerve root is involved, you can easily diagnose by just doing the neurological examination of motor, sensory and the reflexes. You can easily diagnose that yes, this is the region of the spine which is involved by the osteophyte. So there are some risk factors. Those who are the patients who develop this cervical spondylosis, patients who have occupational trauma, who have family history of neck pain, spondylosis, some congenital problems, blocked vertebrae can develop cervical spondylosis. Then smoking is one of the risk factor, anxiety and depressions. So these patients can develop cervical spondylosis. Important investigation here is plain X-ray. First is the plain X-ray, AP lateral. You can, if you wish, you can go for the oblique view as well. There will be joint space narrowing. There will be sclerosis of the end plates. There may be some osteophytes. There may be some small cysts which are present. It is like osteoarthritis. So all those features of osteoarthritis can be present. And in these patients, if patients have neurological deficit, MRI has a definite role. So here in this condition, you can go for the MRI. So MRI is the preferred choice to rule out either myelopathy or radiculopathy. So these are the basically differential diagnosis of radiculopathy and myelopathy, and definitely a differential diagnosis for the cervical spondylosis with neurological symptoms as well. So there may be some like disc herniation, brachial neuritis, thoracic outlet syndrome, presence of shoulder related rotator cuff problems. They all problems can mimic a fibromyalgia. They all problems can mimic like a cervical spondylitis. Even think of trauma, tumor and tuberculosis. Any tumor, any type of tuberculosis around the spine can mimic like a spondylitis. So when to refer those patients? If you suspect malignancy, infection and inflammation, these are called as the red flag sign. ये red flag signs यहाँ पे ज़्यादा matter करते हैं. High grade fever, weight loss, unexpected weight loss, history of malignancy in the past, then history of inflammatory arthritis, history of tuberculosis, patient who are immunosuppressant, patient have intractable pain, excruciating pain, and then tenderness of the vertebral body. If you able to demonstrate the tenderness on the vertebral body, that you can suspect that something is wrong in the vertebral body. In those patients, you can send. Normally, there may be mild tenderness in cervical spondylitis. There may be some spasm of the neck muscle in the spondylitis. But if you can elicit the marked tenderness, then definitely it is something else, not the cervical spondylitis. Then if patients develop myelopathy kind of symptoms, or patient is having multiple fractures like multiple myeloma, or patient is a case of severe osteoporosis, then you can refer those patients. Now coming on to the lumbar spondylosis, it is the same as the counterpart of cervical spondylitis. There is nothing much, but the differentials are certainly, other differentials are also common, like ankylosing spondylitis. Prolapse intervertebral disc is more common in the lumbar region, so it changes. So patients present with a lower back pain, stiffness after the prolonged activity. There may be radicular pain starting from back goes to the leg. कहते हैं patient यहाँ से लेके नीचे तक डर जा रहा है, ठीक है? So it is not always a disc which is causing the pain. It may be lumbar spondylosis where the osteophyte is impinging on the nerve root and causing radicular pain. And there may be some abnormal sensations, tingling, numbness. There may be weakness, changes in the bladder and bowel activities. पेशाब रुक के आ रहा है, ठीक है, या स्टूल पास नहीं हो रहा, इस तरह की कंप्लेन अगर आती है, then you can suspect that this could be. Again, in these cases, simple X-ray, if you can diagnose them very well on clinical examination, then simple X-ray will suffice the purpose. And if there is a radiculopathy, or if you suspect that it could be a cauda equina kind of thing, जो आपका ड्यूरा वगैरह वहाँ पे भी कंप्रेस कर रहा है, नर्व रूट को नहीं कंप्रेस कर रहा है, सेंट्रल कॉर्ड है, then MRI would be the choice. These are the differentials, like intervertebral disc prolapse. It may be acute or chronic. Many times acute cases can be easily diagnosed, but in chronic cases they mimic like a lumbar spondylosis. There may be cauda equina syndrome, where there is a loss of reflexes, saddle back anesthesia, and involvement of the bladder. Patient with the ankylosing spondylitis can mimic, because in those patients not only the spine is involved, there is also the involvement of the sacroiliac joint. So because of the ossification of various ligaments, the back remains stiff and they mimic like a lumbar spondylosis. Then spinal cord tumors, infection, and spondylolisthesis. Anything can be a differential diagnosis for the lumbar spondylosis. So red flag sign, again, patients who are developing any sort of neurological problems has to be referred immediately. Widespread weakness, loss of sensations, myelopathic involvement, low motor neuron signs. If you suspect that there is a cancer, there is an infection, immunocompromised patients, if you can demonstrate the tenderness, and then if there is patients who have recent history of surgery in the spine, then there could be some post-operative infection could be the cause of low back pain, and then osteoporosis. All those patients have to be referred immediately to the other system of medicine. Now, another thing is fibromyalgia. This is really very challenging because it's a kind of a diagnosis of exclusion many a times. Okay. There is no specific test available to diagnose this. So there is a chronic widespread pain, and there may be tenderness without specific organic disease. If you do biopsy of that particular area, you will not find anything. There will be no pathology inside. लेकिन मरीज को दर्द हो रहा है, ठीक है ना? So and there are flare-ups. कुछ दिनों ठीक थे, फिर कहने लगे फिर से दर्द चालू हो गया, है ना? Then they are associated with न्यूरोसाइकोलॉजिकल सिम्टम्स, फटीग, कहते हैं सुबह उठते हैं तो फ्रेश महसूस नहीं करते, या रात में नींद ही नहीं आती. कॉग्निटिव सिम्टम्स हैं लाइक डिप्रेशन, एंग्जाइटी. यूजली फीमेल्स आर इन्वॉल्व अगेन इन दिस इन कंडीशन. And these are because of some sensory disturbances, or maybe because they have increased perception to the pain, or because of the low threshold of the pain, or increased sensitivity to the pain because of the hyperalgesia kind of thing. So these things. So when to suspect? Whenever there is a widespread pain, bilateral, दोनों तरफ हो रहा है, दोनों लिम्ब में हो रहा है, neck में muscle, neck, shoulder, muscle pain, maybe joint pain. Joint pain is usually rare, but body में pain होता रहता है. Maybe fatigue, unfresh in morning, early awakening, morning stiffness, minor activities aggravated the fatigue and pain. There may be some cognitive disturbances, difficulty with the attention and doing task. There may be some memory loss also, anxiety, depression, headache, and paresthesias. There may be problems related to GIT. There may be problems related to the sleep, bladder control. Any problem can be there. So in such patients we can suspect. We have to do certain tests. Definitely we have to go for the X-rays also, some blood test also, even rheumatoid factor, anti-CCP आप करा के देख लो, just और कैल्शियम प्रोफाइल करा लो, just to rule out कि कुछ और तो नहीं है. So ACR again have developed some measurement of fibromyalgia and symptom severity. They have two criteria. One is the widespread pain, and another is the severity score. And they determine this, and the symptoms should be for at least for the 3 months. Also, there should not be any other problem. Third criteria: patient does not demonstrate any other disorder that would otherwise explain the pain. 3 महीने की प्रॉब्लम हो, कोई और बीमारी ना हो, और ये वाइड स्प्रेड पेन और ये जो सीवियरिटी स्कोर है, इफ दे आर प्रेजेंट. So this is the basically they have made like quadrant बना दिए उन्होंने. There are 4-5 quadrant. One is axial, one is right upper limb, right lower limb, left upper limb, left lower limb, and axial. Based on that, they have 19 points. And based on the whether patients have fatigue, trouble in thinking, walking up tired, unfreshed, and then pain or cramp in the lower abdomen, depression and headache. Based on these they have made 12 points. So total 31 points हैं इनके. So based on this, if you fit कि भाई patients have particularly right upper limb, there is a pain. Left lower limb, there is a pain. Axial side, there is a pain. So you just calculate those points, and based on those points, you can easily diagnose. It could be a fibromyalgia. So see for this example, all the red squares represent the pain or tenderness during past 7 days, whereas blue squares represent not painful areas. So 1, 2, 3, 4, 5, 6 points. So widespread pain score is 6. And symptom severity, there is a slight fatigue, there is a severe trouble thinking, and there is a severe problem in waking up. And then there is a problem, you can give pain or cramp in the lower abdomen, depression, and there is headache. So based on this, you can just calculate. Suppose in this point it comes out to be 9. So total 6 and 9, total 15 points are there. And then you have to see for these two also. You have to rule out the pain should not be because of some other problem. and the symptom should be at least for the 3 months. Then you can diagnose fibromyalgia. So no X-ray, no laboratory test for the fibromyalgia exist. So you can go for battery of other tests to just rule out other problems so that you can easily diagnose the fibromyalgia. So these are the differential diagnosis because it involves multiple organ systems. So rheumatoid arthritis is one of the important differential diagnosis of this particular condition. Then SLE, polymyalgia rheumatica, polymyositis, Lyme's, hypothyroidism, because hypothyroid can involve any organ system. So these could be the differential diagnosis. Red flag, whenever there is a widespread pain, hypersensitivity to touch, muscle cramps, muscle stiffness, joint stiffness, persistent headache, migraine, GI disorders, elevated reaction to sensory triggers, severe fatigue, weakness, depression, anxiety. If all those things are also present, just be cautious and refer those patients. Now this is the last, adhesive capsulitis. I think it is now very common. After the COVID, I have seen so many cases of adhesive capsulitis. So also called as the frozen shoulder, there is a progressive pain and stiffness and restricted movement of the shoulder. Usually resolve spontaneously. 1-2 साल में 3 साल में ख़त्म ही हो जाती है, ठीक है, लेकिन जब तक रहती है तब तक सबकी नाक में दम करके रखती है, बहुत दर्द होता है, ठीक है, आप अपनी डेली रूटीन एक्टिविटी भी नहीं कर पाते. सो एसिम्प्टोमेटिक और in 40% patients may have mild to moderate persistent symptoms. So American Shoulder Elbow Society has given definition. It is a condition characterized by the functional restriction of both active and passive shoulder motion, for which the radiograph of the shoulder are essentially unremarkable. ऐसी बीमारियां दी हैं कि जो पता ही नहीं चलता क्या है इसमें, ठीक है. So there will be loss of abduction, हाथ नहीं उठा पाएगा, और loss of external rotation, पीछे नहीं ले जा पाएगा. तो दोनों मूवमेंट इसमें चले जाएंगे. इंटरनल रोटेशन also restricted later on. These are the common problems which can be there in the shoulder and can mimic the adhesive capsulitis. Mostly the problems coming from the cervical spine, radiculopathy, they usually mimic. Because of the radiculopathy, patient is not able to, do work because of there is a pain in the arm, there is a weakness. So it mimics that. This is because of the shoulder problems, but because of the basically cervical spondylitis. Patients with myocardial infarction, they are more prone for the shoulder adhesive capsulitis. Diabetes also, thyroid, diabetes, but these are the problems which can be mimicking. So diabetes onset is usually 40 to 60 years, and there may be some history of trivial trauma. Patient correlate करता है, हाँ डॉक्टर साहब गिर गए थे, उससे लग गई. आपको कंफ्यूज करने की कोशिश करेगा कि हाँ गिर गए थे इसीलिए लगी है, ये उसी की वजह से हुई है. तो आपको सोचना पड़ेगा दिस इज ए पोस्ट ट्रॉमेटिक स्टिफनेस और इट इज़ ए एडहेसिव कैप्सुलाइटिस. तो यू हैव टू आस्क कितनी तेज चोट लगी थी. You have to ask for the severity and the duration after which the symptoms were remained in that patient. So females are involved, and in quarter of patients it can be a bilateral disease. Causes could be primary, which are idiopathic, पता ही नहीं क्यों होते हैं, or because of the secondary. Secondary causes could be the intrinsic causes within the shoulder joint, like biceps tendinitis, calcific tendinitis, rotator cuff diseases, or because of the extrinsic, because of cervical radiculopathy, chest wall tumors, or because of the shoulder trauma to the clavicle, to the AC joint, to the humerus, anything can cause. Or sometimes the systemic disease like diabetes, hypothyroidism, and hypoadrenalism. Hypo and hyperthyroid both can be the causes. So diagnosis: spontaneous and sudden onset of severe pain, or after the minor trauma maybe. Pain is usually in the night. दिन भर तो पेशेंट आराम से रहता है, रात में बहुत दर्द करता है, सो नहीं पाता, करवट नहीं ले पाता. So it interferes with the sleep. So if you examine patient, there may be some tenderness which is usually mild, or there may be restriction of both active and passive movement. So there are three stages of this disease. This has to understand properly, and they have a variable duration. Stage 1, painful phase. Usually it is called as a freezing phase, 2 to 9 months. Patient present with a severe spontaneous onset of severe pain, and it goes on increasing. And most of these patients are not at all relieved by any analgesic. ठीक है ना. फिर ऐसे patients में we have to give intra-articular steroids to relieve the pain, or give some physical therapy to relieve the pain. In second stage, there is a gradual reduction of, because of the, in first stage, reduction of joint range of motion starts. So we encourage patient, despite the pain, you just do exercises, otherwise it will become stiff. But in second stage, pain become less and less, and rotation movement become more and more reduction of the range of motion. And in third stage, thawing phase, there is a gradual improvement in the shoulder, elbow, shoulder motion. So these stages can vary from 1 to 3. If you can see this phase because of increasing pain, then there is a loss of motion, and in third phase there is an improvement in the range of motion. So we have to do certain tests, and based on those tests we have to exclude the other diagnosis like rotator cuff tear, where there is a patient, the movement can be done passively easily, but once you stop holding the arm, there will be sudden drop because of the rotator cuff. And if any patient can do these three things, scratch test, ऐसे कर लो, ऐसे कर लो, ऐसे कर लो, अगर आप scratch कर पा रहे हो, that you are safe. So this is a scratch test which is given. Investigation, you can do X-rays to rule out other pathologies. X-ray is one of the investigation. MRI we don't do. In routine cases, we rely on clinical history and the examination part. MRI is not at all recommended in these cases. So these are the differentials. Because the shoulder joint TB is a dry kind of TB. दर्द ही दर्द होता है, ना swelling होती है, ना effusion होता है, ना पस आता है, कुछ नहीं आता है, दर्द हो रहा है बस. तो ऐसे infection is one of the important differential. Then post-traumatic stiffness. Then if there is a trauma, then dislocation and rotator cuff injuries. There may be some impingement of the rotator cuff, biceps tendinitis, AC joint arthritis, cervical spondylosis, and glenohumeral arthritis. These are some of the differentials for the, and we have to always rule out this trauma, tumor, and tuberculosis. So red flag, If any patients who have redness or signs of inflammation, please refer. Any patient in whom you suspect is a case of rotator cuff injury, you can refer. Then unexplained wasting, motor or sensory neurological deficits, trauma, these patients can be easily referred. Treatment, usually initially we start with the painkillers, and if it is not relieved, then we can also give the intra-articular steroids, analgesic, and if it is possible, then we also give the treatment for the underlying causes. Thank you.
Thank you, Dr. Jain. I request all the participants, if they have any doubts or queries regarding this session, they may ask doctors.
Recently, I read an article that this rheumatoid arthritis may be due to subtogranulatum, some bacteria. Is it true?
See, these are all theories. All theories. They are the scientists are trying to find out the cause of a problem in order to give some treatment. These days there is a role of gut microbiota, gut microbiome, है ना, उसको लोग डिस्कवर कर रहे हैं. जॉइंट्स में भी लोगों ने पाया है कि these particular bacteria, not only the gut, it is also present in the joint. So because of the dysbiogenesis of this gut microbiota, any etiology can be possible. Even people are searching it in the cancers also, not only arthritis but cancers also, they are searching for this. So but these are all, all these things are at the experimental level. There is no foolproof. नहीं तो हर आदमी को जो है आप एक वाइजीलैक की एक गोली खिला दो, कह दो इससे आप ठीक हो जाओगे, आपका गट माइक्रोबायोटा ठीक होगा, आप ठीक हो जाओगे, है ना, यही तो होगा ना.
Ayurveda is told the same thing, sir. That means undigested food material may causes all these rheumatological spectrum.
तो खैर आयुर्वेद का तो कंसेप्ट ही यही है, मैंने बताया ना, वेल बीइंग और आप कैसा फूड खा रहे हो, है ना, और वो उसका एंटी करता है. जहाँ लगता है कि जैसे कहते हैं ना ठंड लग गई तो मदर क्या करती हैं, सोंठ दे देती हैं, काली मिर्च दे देती हैं, क्योंकि वो गर्माहट पैदा करती हैं. तो आयुर्वेद तो उसी कंसेप्ट पे है ना, जिस चीज़ से जो चीज़ हो रही है उसके अपोजिट चीज़ को दे दो आप, है ना, तो उससे ठीक हो जाएगी. हाँ,
बहुत कस्टमरी हो गया और पेशेंट्स 40 या 45 इयर्स के बाद, स्पेशली फीमेल पेशेंट्स, दे कीप ऑन टेकिंग कैल्शियम सप्लीमेंट्स.
यस, कैल्शियम इज
ऑस्टियोआर्थराइटिस पे इसका ऑस्टियोफाइट फॉर्मेशन या जैसे आपने कहा बोनी एलिमेंट्स की ग्रोथ में इसका कोई रोल?
देखो, ऐसा कुछ नहीं है कि इफ़ यू टेक मोर कैल्शियम देयर विल बी मोर ऑस्टियोफाइट फॉर्मेशन. कैल्शियम मेटाबॉलिज्म एक अलग कंसेप्ट है, एक अलग चैप्टर है. बॉडी में कैल्शियम मेटाबॉलिज्म की बहुत सारी एडवांटेजेस हैं, ठीक है, उसमें विटामिन डी का भी रोल है, और ये पाया गया है, हाँ, कैल्शियम, मैग्नीशियम और भी एलिमेंट्स हैं, और इट हैज़ बीन फाउंड दैट दीज कैन हैव अ गुड रोल नॉट ओनली फॉर द बोन बट फॉर एक्टिविटी ऑफ अदर ऑर्गन्स ऑल्सो. जीआई की मोटेलिटी है, कार्डियक कॉन्ट्रैक्शंस हैं, उसमें भी यूज़ होता है. तो ऐसा कुछ भी नहीं है कि आप ज़्यादा कैल्शियम दोगे 60 ईयर्स फीमेल को तो बोन में जाके डिपॉजिट हो जाएगा या किडनीज में डिपॉजिट हो जाएगा, अनलेस दे आर प्रोन फॉर इट. ठीक है ना. एंड द नॉर्मल पर्सन एज पर द मॉडर्न मेडिसिन requires a certain quantity of calcium and vitamin D on a daily basis for doing their metabolic activities. ठीक है ना.
Sir, I have one question. This side. Sir, in our practice, we generally find in our OPD that there are certain patients, those who used to come with a problem of lumbar disc prolapse or protrusion or disc bulging like that. Then we used to give some medicines, and further they used to ask for laminectomy in our district hospital surgery department. Then they undergo this process, and after 1 or 2 years, again they have the same complaints with the same problems. I have seen many cases like that. So I have two questions. So at what stage a patient should be advised to undergo laminectomy? And the second question is, if post surgery, what are the precautions to be taken so that those things should not happen again?
See, the problem is because of the lumbar spondylosis. It is because of the lumbar spondylosis, many things can happen. Not only the vertebral body is involved, there may be there are certain joints, facet joints, oncovertebral joints. There are disc also. The multiple factors can cause pain. If patient have any neurological problem, and if you can easily diagnose that yes, this neurological problem is because of this particular issue, you go and do laminectomy, patient will be relieved. लेकिन जब आप ये देखो ना कि लंबर स्पॉन्डिलोसिस एक वर्टिब्रा में तो होती नहीं है, वो तो इट इन्वॉल्व्स मल्टीपल वर्टिब्रा एंड इट इज़ ए ऑनगोइंग प्रोसेस. इट्स अ डीजेनरेटिव, इट्स अ ऑनगोइंग प्रोसेस. तो अगर आपने एक जगह की लेमिनेक्टमी कर दी, केवल लेमिनेक्टमी करी है ना आपने वहाँ पे फ्यूजन तो नहीं किया है ना. अगर आप फ्यूज़ कर दोगे तो पेशेंट को हो सकता है आराम आ जाए, लेकिन अगर केवल लेमिनेक्टमी करके छोड़ दोगे तो पेशेंट का स्पाइन वैसे ही अनस्टेबल हो जाएगा और पेशेंट को और पेन बढ़ना चालू हो जाएगा. ठीक है. और मैंने आपको स्टार्टिंग में ही बोला था, वाई वी कैप्ट दीज थिंग्स, बिकॉज दिस नो 100% क्योर. ठीक है ना, इसीलिए नहीं होता. मॉडर्न मेडिसिन में भी बहुत सारे फ्लॉज हैं, ऐसा नहीं है. ठीक है ना. तो हमें एज ए होल लेके चलना पड़ेगा, तभी हम पेशेंट को ठीक कर पाएंगे. और लेमिनेक्टमी केवल उन्हीं पेशेंट में करनी चाहिए जिसमें पेशेंट को न्यूरोलॉजिकल सिम्टम्स हो रहे हैं. इट इज़ नॉट दैट सर्जरी फॉर द लो बैक पेन पर से. राइट.
सर एक क्वेश्चन है मेरा भी. सर ऑस्टियोआर्थराइटिस या रूमेटॉइड आर्थराइटिस में हम एमआरआई को अवॉइड करते हैं या कुछ ज़्यादा फायदा नहीं है. तो सर एवीएम के अंदर भी हम सर कई जो सर्जन्स होते हैं वो केवल एक्सरे को ही प्रेफरेंस देते हैं और कई एमआरआई को देते हैं. और सर जैसे कि आज कोई ट्रीटमेंट किया, 6 महीने ट्रीटमेंट करने के बाद भी अगर हम उसको एमआरआई करवाते हैं तो बहुत ज़्यादा हमें पता नहीं लग पा रहा कि भाई वो कुछ ठीक हो रहा है कि नहीं हो रहा. और एक्सरे में भी बहुत स्लाइड सा पता लगता है. सर उसके बारे में कुछ बताएं.
देखो, इफ़ यू सस्पेक्ट ऑन एक्सरेज यू सस्पेक्ट देयर इज ए AVN, always go for the MRI. Why? Because the MRI, if suppose there is a patient of avascular necrosis of the hip, you have to see whether this patient have stage 1, stage 2, stage 3 or stage 4. Treatment of AVN आज की डेट पे it depends on stage at which it is diagnosed. Stage 1 has definitely different treatment than stage 2. Right. So in these cases, in AVN, particularly in AVN, if you suspect that this case could be avascular necrosis, you must go for MRI. And also, not only that, because the X-ray looks completely different. It is not normal X-ray, not like osteoarthritis X-ray. So in those cases also, you have to see if there is any other pathology which is causing the problem, because many times we suspect that ये तो दिख रहा है AV नहीं होगा, AV नहीं होगा, अब उसको ट्रीटमेंट दे रहे हैं, आराम ही नहीं आया, बाद में पता चला TB था. ठीक है. तो you have to suspect clinically that yes, this is a case of avascular necrosis, and we have to go for MRI to determine which stage of disease it is falling, to give a best treatment.
Sir, after COVID, a lot of people are suffering with this hip joint AVN. Is there any relation to this coronavirus, sir?
Yeah, good question. So, no, it is not a steroid always. So, the avascular necrosis post-COVID is because of two reasons. One is because of the virus itself, and another is because of the use of the steroids. The virus which was the COVID-19, it was supposed to cause hypercoagulation kind of, uh, uh, coagulopathy kind of things in the body. So it is a subject of investigation, and people are doing it because I have also studied this. Many of the patients who had COVID and not taken any treatment like steroid and developed avascular necrosis. But steroid is one of the factor which is causing the avascular necrosis. Also, it is not the at which dose of steroid it is causing the avascular necrosis. Any dose of steroid, even a single dose of steroid can cause AVN. And even a cumulative dose of 1500 milligram doesn't cause avascular necrosis. So there are some genetic factors also involved in those patients in whom we have used steroids. So now there are three factors, three theories are going on. One is because of the vasculitis, hypercoagulation, because of the virus which is causing the avascular necrosis. Second could be because of the steroid, and third because some develops and some doesn't develop. This is the genetic factor which is causing the problem.
So one last question.
Yeah, please.
Sir,
Is there any role of the vaccine also which in hypercoagulation?
Vaccine, which vaccine?
Covishield, some of
No, I don't have idea.
so there is one last question.
Yes.
So can you elaborate in short the role of pregabalins or methylcobalamins in various joint pain or disorders?
No role. There is no role. Not at all.
Generally, we used to see in all prescriptions. Does they have any role in
Nahi,
reducing the
nahi.
pain or increasing the nerve sensitivity or like this?
There is no role at all. My first line of treatment for osteoarthritis in every patient is paracetamol. My. ठीक है? जब पेशेंट आराम नहीं आता है, then I add one of the COX-2. अगर उससे भी आराम नहीं आता है, then I switch over to another COX-2. ठीक है ना? And then I always encourage for the other therapies also. सिकाई करो, लाइफस्टाइल मॉडिफिकेशन करो, एक्सरसाइज करो, वेट रिडक्शन करो, ठीक है ना? आई इंकरेज दोज पेशेंट्स. मैंने शायद ही कभी किसी पेशेंट को ओपियोइड दिया होगा, कभी नहीं देता मैं. कभी भी किसी भी ऑस्टियोआर्थराइटिस पेशेंट में आज तक मैंने एक भी इंट्राआर्टिकुलर इंजेक्शन नहीं लगाया.
Nowadays it's in huge practice of giving intra-articular.
वही इसीलिए मैंने जब अपनी स्लाइड्स को रखा था, ठीक है, तो मैंने इसी बात पे एम्फसाइज किया था कि प्लीज़ डोंट यूज़ देम, प्लीज़ डोंट यूज़ देम. दीज आर ऑल मार्केट ड्रिवन. आप इंट्राआर्टिकुलर स्टेरॉइड लगा देते हैं, रामबाण की तरह काम तो करता है, लेकिन कार्टिलेज को बिल्कुल बर्बाद कर देता है. आई एम ए आर्थोप्लास्टी सर्जन. आई डू जॉइंट रिप्लेसमेंट. Every year I do more than 100 knee replacements. Those patients who receive steroids, उनका पूरा cartilage eburnated होता है. It progresses the osteoarthritis. It relieves pain. Definitely there is a relief in pain, but it causes problem.
Thank you, sir. Just one more question. This Ayurvedic doctors, as Ayurvedic doctors, we generally use lot of oil applications on the place of where we have pain. In osteoarthritis and arthritis or rheumatoid arthritis. But generally I find back home, I'm from Tamil Nadu, the modern doctors there, they say there is no use of applying the oil. Can you give us your viewpoint on that?
देखो मैं आपको बताऊं, देखो एक बात मैं हिंदी में समझाता हूं आपको. हम अपनी फील्ड के स्पेशलिस्ट हैं, ठीक है? एक मिनट. आप अपनी फील्ड के स्पेशलिस्ट हैं. आपको ये मानना होगा कि जितना मैं अपनी स्पेशलिटी को प्राउड करता हूँ, उतना आपको भी अपनी स्पेशलिटी पे प्राउड करना है, ठीक है ना? कौन क्या कह रहा है, कौन क्या, हाँ नहीं एक मिनट, कौन क्या कह रहा है कि वो ऑयल वर्क करेगा नहीं करेगा, ठीक है ना?
My question was,
आपको अपनी पैथी पे बिलीव करना होगा।
नहीं बिलीफ तो है, मेरा क्वेश्चन ये था कि मॉडर्न मेडिसिन
डिस्कशन ड्यूरिंग टी ब्रेक बिकॉज़ वी आर रनिंग शॉर्ट ऑफ
एक मिनट में बता दूं कुछ। हाँ,
माय क्वेश्चन वाज कि एलोपैथी में कॉन्सेप्ट ऑफ आपका मेडिसिन में एक्सटर्नल एप्लीकेशन का
हमारे यहाँ एक्सटर्नल एप्लीकेशन ऐसा नहीं है। देखो मॉडर्न मेडिसिन इज ए एविडेंस बेस्ड मेडिसिन। आप कहोगे तो मैं आपके लिए एक थीसिस कर दूंगा, ठीक है, और हो सकता है उसमें अच्छे रिजल्ट हों, बट यही मैं कहना चाहता हूँ कि हमने अभी अपनी प्रैक्टिस को, जो आयुर्वेदा है या सिद्धा है या यूनानी है, हमने अभी उसको सही से रिसर्च नहीं किया है। वो लोगों ने किया था और हम उसको फॉलो कर रहे हैं। अभी समाज जो है ना, वो एविडेंस मांग रहा है हमसे, जबकि वो प्रूवन है, कब से प्रूवन है, लेकिन अभी भी एविडेंस मांग रहा है। ठीक है ना? ये मेरा कहने का मतलब।
बहुत खुशी हुई सर आपसे मिलके, बिकॉज